care, but the bigger question that was being asked was, what was it about the current environment in New Zealand that was leading such fast rollout and take-up of this particular model of care? So we certainly also looked at some of the theories about how ideas diffuse across systems, particularly how health service innovations diffuse across systems. So we were asking questions about healthcare homes, what they were illustrative of in terms of understanding primary care change in New Zealand. But I had to conclude that this still was only a partial picture. Much is still not documented about change. The evaluations we had access to, it was quite a piecemeal picture. When the appetites for evaluative research were high, the centre had lots of reports, but more recently there hasn't been such a high appetite. So we knew of certain innovations, but we didn't necessarily have a research evidence on what they were concluding. So for that reason, as we go through and present our results, there are things that we're certain of and there are things we're less certain of, just given the paucity of information. So both Phoebe and I will be presenting as we go through. Thanks. So this is we did start the whole report with a historical mapping of change in New Zealand. The bottom line here represents the reports I referred to that we drew on, the times when the evaluative appetite was high for what was happening. But equally, as an overview, New Zealand's had a period, particularly in the 90s, of quite a lot of organisational change in the health sector, looking at creating quasi-markets, looking at purchase of provider splits. And for primary care, this heralded a shift from small independent general practices to the need to collectively negotiate contracts with an evolving array of purchases. So what you saw in the 90s were different purchasing arrangements sort of rising and falling. And there's a circle there to represent 2001, the yellow circle talks about the primary healthcare strategy. That's actually, I think, the enduring shift in New Zealand primary healthcare in the last few decades. And in fact, a lot of the key elements that were introduced in this particular strategy still endure now, nearly 17 years later. So we'll talk a bit now about this strategy and the change that it introduced in the system. You'll recognise, if you've got a background in primary care, a lot of the themes that you see internationally about the importance of population health, the importance of team-based care, links with community services and cultural competence. All these ideas were introduced in this strategy and the move away from more narrow provision of primary care. And certainly at the same time it was released, there was a real recognition of the fundamental role primary care was needed to play in the healthcare system in New Zealand, a recognition a lot of focus had gone on hospital and secondary care, and this needed rebalancing. The key vehicle through which change was going to occur was capitation funding. So before New Zealand New Zealand general practices were funded on a fee-for-service basis. Since the 1940s, that fee-for-service originally was supposed to be 2/3 of the cost. By the 80s, that had eroded away to only covering 1/3 of the cost of a visit. So large out-of-pocket expenses were causing real access concerns for vulnerable populations in particular. So the move to changing financing was a very significant part of what was happening in the primary healthcare strategy. Significant new money went in as well to ensure that primary care was more accessible, but at the same time, capitated funding was introduced and managed by new kind of collective organisations called primary health organisations that had enrolled populations for which this needs-based funding was introduced. So general practices in New Zealand could voluntarily pick which primary health organisation they linked up to and then received a portion of capitated funding to deliver care to particular population groups. But there were two, and this endured, two groups of sort of practices going through. The first group did get more funding in return for very low fees. The second group did have no regulation around the fees they could charge on top of capitation, though a fees review kicked in later on in a few years in. But this is just to reflect, so while we talk about capitated funding for primary care in New Zealand, it's still blunted by the fact that fees can still be charged by general practices on top. Not all of them do. Some of them in return for more funding from government have very low fees, but others still have a fee-based structure on top of the capitation they receive. So given that happened in 2001, what we can see today, and this slide shows the current policy settings. As I said, a lot of the key changes endure, but what you can see at a national level is the recent New Zealand healthcare strategy, priority given to shifting resources to primary care, though looking at where the funding has actually gone, there's still been a lot of incentives on the 20 DHBs to still keep funding going to secondary care. So you can't necessarily see the major shifts in actual where resources are going, even though there's been heralded changes for quite a while. The most recent development in terms of a policy setting for primary care that's different is an alliance framework to include primary health organisations alongside DHBs to actually create the plan for what will be delivered in each district across New Zealand. So originally DHBs would make the key planning decisions. Now, along the lines of a higher trust environment, there's an expectation that those plans are developed alongside PHOs to then think about the longer-term resource provision in each district. And certainly what you're also seeing is we had a decade of tagged funding going into primary care to support specific population groups, but that's now become more flexible, allowing both PHOs and district health boards to make different calls in how they contract for primary care in each district, without having to actually meet a lot of national requirements for particular funds to go to particular places. That doesn't mean there still aren't ring-fenced funding for mental health, and there's still a tendency for other new initiatives to come through with ring-fenced funding, but we were seeing more flexible options going down into the system. The other kind of key policy setting for PHOs is they've been relatively stable. There was a move originally, there were 80 of them when the strategy was first introduced, but through both directions and economies of scale, they're now down to about 32 PHOs. And as that change process has shaped up, we could certainly see evidence that they were now leading a lot of change from the middle of the system. So quite light touch policy directions from the national policy top of the system. But we could see, and we'll talk further about this, that given their stability now over 17 years, you could see them actually adopting new models of care and sharing information amongst themselves in new forms of collaborative. That was a powerful sign as to why the healthcare home was moving so quickly across New Zealand. And then finally, I just want to reflect that not all general practices in New Zealand look the same. We've had a long history of population health practices emerging always at the forefront of new models of care, linking with community services. We've had Māori and Pacifica organisations, often owned by iwi and other community-linked organisations, but at the same time we've had business models for GP practices focused on continuity of care for particular groups of population. So a wide plurality of general practice types, which has meant, given the voluntary nature by which each practice could choose to join different PHOs, what we also saw was PHOs that we interviewed reflecting back they could only move as fast as their different member practices were prepared to go in actually introducing change. So looking at the international literature on these collective primary health organisations, these meso-level health organisations, you could see evidence that actually created from the top, they often don't reflect the professional culture of general practices, and they've had a rocky history in some parts of the world, but in New Zealand they have very much emerged from the bottom and organically allowed to develop. And there is an argument that then they have got very well attuned to align both the financial and professional incentives of a whole range of different general practice types in New Zealand. So as I said, we were using the healthcare home and that model of care and how it was being picked up by different PHOs and general practices across New Zealand as illustrative of a number of broader trends. This slide here summarises some of the components of the healthcare home. So Helen Parker talked last month in quite a lot of detail of what the healthcare home looks like in a New Zealand context. This flags here, it's both a whole lot of smart use of new technologies to manage demand, and equally by managing demand better for practices, they open themselves up for more time on care planning for patients with high needs and increase hours of access and better links with community health services. So an opportunity through managing demand better to open yourself up for more proactive care. And that certainly, as I said, was our starting point to ask, well, what's happening in the system that's enabling this new model of care to spread quite so quickly and quite so enthusiastically? At the same time as looking at the healthcare home as an example, we wanted to use a model to help us understand how system change and innovation works. So this model by Tricia Greenhow and colleagues around the diffusion of health service innovation, we found particularly helpful, giving us a whole lot of features to look at and assess whether we could see those in evidence to help our analysis of what was happening with innovation in New Zealand in the primary healthcare system. This model starts at the centre with the attributes of any change, and then looks more broadly outwardly about the outer context, some of the antecedents for change you would expect to see, some of the attributes of the innovation itself. We focused on those three particular areas rather than go in depth at what the healthcare home was. We were looking at what were the features in the broader system environment that seemed to allow this to emerge and spread. So that led us to look at the outer context, as I said, the policy settings, what were the incentives out there. It led us to look at some of the ideas around the tension for change, what was happening in terms of primary health organisations sort of stepping in and leading change, how powerful were they in doing this. And we also looked a little bit at the healthcare home model and asked, did it have a number of attributes that suggested it was better than the status quo, all those ideas that suggest others would pick it up more easily because it clearly had a whole set of new advantages. So using this model and equally the healthcare home, we ended up with some key conclusions about what was happening in the system, and Phoebe's now going to look at those enablers first of all.
Yes, so as Leslie mentioned earlier, there were some enablers that we felt there was stronger evidence to suggest, and there were some areas where we were less certain, but we felt were kind of worth mentioning and would warrant further exploration. So the first of the enablers was the stability in the organisation of the healthcare system in New Zealand, so particularly relative to other periods in history where there have been lots of big changes. We've now had DHBs in place since 2001, the configuration of PHOs in most areas since 2011-12, and district alliances since 2013. And so this has really created supportive conditions for innovations to emerge from the middle of the system, as Leslie outlined earlier. And we also, there was a sense that the kind of organic nature by which PHOs had developed and evolved had avoided perhaps some of the downsides that other countries had experienced, where particular configurations were kind of tried to be forced from the top down, and that's quite a different experience to the New Zealand kind of evolution of PHOs and the slow incremental change we've seen. The second was that some PHOs are clearly acting as facilitators of innovation and ensuring that new services are developed in ways that align financial and professional incentives for general practices. In some parts of New Zealand, PHOs are acting more independently, and others they're working very closely with DHB partners. often providing seed funding to general practices to enable new ways of working. But equally, where funding is not forthcoming, PHOs have been able to make progress. And we've also observed that those PHOs implementing the healthcare home bundle of innovations have put considerable thought into the change management capability of different general practices and the role that they can play in supporting practices to implement this new model of care. And the third on this slide was just this emerging collaborative network, the Healthcare Home Collaborative, that has a website. You can go and find out lots of things have been published there. So in terms of sharing resources and insights, setting standards, there's some benchmarking. The first round of certifying practices as healthcare homes has taken place. And there was a sense that areas that are coming kind of onto the healthcare home journey later on are able to really utilise all this insight and learning and kind of move quite quickly to implement the model. And so this was enabling the acceleration and spread. And also that as a consequence of this sharing, patients in different areas around the country would be more likely to have a kind of consistent experience of this model of care. So enablers that we were perhaps less certain of. The first is the current light touch permissive policy environment that Leslie described. So we did hear kind of arguments that perhaps a lack of central leadership has meant that innovations aren't being supported as well as they could be. Although the kind of flip side that we saw of that was that there was a case to say that this permissive environment kind of coupled with really enthusiastic leaders and areas that had these good legacy of relationships had supported the emergence and refinement of this model of care, and that actually the healthcare home as a grassroots initiative was perhaps, could make it more sustainable in the long term, particularly in periods of changing governments and changing national policy. The second on this slide is the injections of funding at key stages in development. So we were able to trace back particular funding streams of models going back into through different periods of history, but equally for many of those we spoke to, it felt like a bit more active backing from the centre at key points would have really accelerated the development of the model. And that actually there had been little, as we called it, policy prodding of areas that were perhaps less interested in picking up new models of care and needed a bit more encouragement from the top. And the third on this slide just goes back to the Tricia Greenhill model. And we kind of observed that our early thinking on this was that actually the healthcare home did possess quite a few of the attributes that made innovations more likely to be adopted. So things like the emerging relative advantage of being a healthcare home practice, and lots of kind of emerging early evidence looks positive. The ability for the model to be broken down and implemented incrementally, and also the ability for it to be tailored to kind of local needs and priorities and settings. And again, this would need to be tested with areas that are have chosen this model and are rolling it out, but also areas that are pursuing other models of care. So Leslie's going to talk a bit about some of the barriers.
So in terms of where we felt more certain we were seeing barriers, as I mentioned at the beginning, the fact that New Zealand's still got this blunted form of capitation was still clearly a barrier to new models of care, or in this case, the new healthcare home model of care, because we got some great examples from particularly those we interviewed of the importance still for primary health organisations working with general practices to help them see how they could still maintain their expected level of income, even though they were now encouraging them to do less costly interventions like telephone triage and online consultations. So certainly the incentives, particularly if for those practices relying on large patient co-payments to keep volumes of care up, was still quite high, and you could see quite creative workarounds to shift and help practices shift from prioritising volumes to delivering more proactive care. what we were also seeing is it was clear that the rollout of the healthcare home was assuming that practices were experiencing increased demand, and equally that they wanted to do something different than a 15-minute appointment. So that did help explain some of the sort of staged rollout we were seeing across New Zealand and across different PHOs, where practices themselves were given an opportunity to decide if they wanted to become part of a first tranche or a second tranche or a third tranche of rollout in terms of doing things differently. And a lot of the funding that PHOs were putting into this model of care was about change management support and helping practices change all the mechanics of how they worked in ways that was quite a challenge to professional cultures within the practice. And this led us also to see the importance of the local history of relationships, so just under the term there, history matters. So, I mean, you could certainly see that those DHBs and PHOs that had a long history of trusting relationships were moving faster to pick up new ideas and focusing on how to use the funding available to both of them more effectively to support innovation than those who were still trying to work through different relationships. So you could certainly see the alliance contracting model that I introduced as part of the policy settings at the beginning was making great strides in some areas, and particularly in Canterbury, great history there of collective understandings of what you needed to do to link secondary and primary care. But equally, there were other difficulties in other parts of the country, given some complex configurations of PHOs and DHBs. And then the next one, we had less evidence to be totally sure of this, but a clear sense that the evidence for healthcare homes and the effectiveness they're having was still undeveloped. Helen Parker presented last week great evidence around Midlands and the context there, but as our research, and Phoebe will talk about this further, our research in other evaluative areas and other pockets of innovation across New Zealand, it often shows that context matters very much to see the change expected, and we're still lacking that broader New Zealand-wide picture of the benefits being seen. Things we're not clear about is how much it does support the equity goals that New Zealand has for its health sector, how much Māori and Pacifica-led practices and PHOs would see themselves picking up some of these healthcare home ideas, and whether they will make a difference to equity is just not known. And this again reflects, as I said, the barriers in the sheer diversity of general practice and PHO types and ownership structures across New Zealand. So there are front runners that have had a population health focus for some time, but for those that aren't front runners, we're not sure how much general practice managers are actually thinking about change, given the propensity to be really challenged by some of the new structures and professional cultures that need to change as part of the healthcare home. So a sense that it's often easy to see the early adopters running with these new ideas, but how quickly the bulk of general practices might be changing, whether there are other innovative models you might want to look at alongside healthcare homes. These were things that we were less certain about, and we're still looking to see greater evidence around.
So as Leslie mentioned, another part of the piece of work we did was to look across the evaluative body of research that the Health Services Research Centre has completed since 2001. You probably can't read lots of those, they're in the report, but here are some of the pieces of work that we looked at. Just to look at what past evaluations can tell us, what are some common themes that are emerging, and what might be some lessons for kind of the next round. And again, what this illustrates really is also the kind of partial picture we do have, and you can, if you do know these reports and see a list of them, you can see that there are periods of history where the appetite for evaluation was higher and we've got some really good insight, and other periods where there's not much to go on, or certain particular areas that were more or less willing to kind of take a critical look at how they were developing. So I don't think any of these themes that we're summarising here are kind of new or groundbreaking, but I think useful to reiterate. And having looked across all of these, here's a quick summary. So firstly, just that change takes time, and significant changes in culture or to see measurable changes in health outcomes, can take many years, and often the implementation period was too short to see these changes, and to kind of embed changes across a primary healthcare system. There were a series of contextual factors that were highlighted across the reports that either helped or hindered implementation and spread. So again, lots of these have come up before, but a kind of legacy of trusting relationships. So it could be interprofessionally, between DHBs and PHOs, between different provider groups. Having stable leadership, the impact of different workplace cultures, for example, across different general practices. The communication and information flows across a region and between providers. This kind of barrier of change fatigue and perhaps a kind of lack of energy or appetite for further change, having gone through rounds of different change initiatives, and also the barrier of workload demands. And then the enabling impact that health IT can have if it's set up well, compatible, and people are able to use it. Thirdly, a sense that collection of good data and analytics in demonstrating change is really crucial, and the need to identify the requirements up front. So I think there was an example in one of the reports where the idea had been to do a big cost effectiveness analysis of a change initiative, and actually the data was later kind of realised to be just too poor to be able to do that. This sense that hospital use and avoidable admissions and ED rates are often the main change that is looked to be gained from an initiative, and often not able to demonstrate impact, or impact is not able to be attributed to the initiative itself. And also recognition that by just focusing on these outcomes, you're actually missing some other really important aspects of care, like patient experience. So a kind of plea to look beyond hospital use. And then finally, just that past evaluations have often been constrained by time frame. So this need to kind of balance starting early to get your baselines, but also to follow up for long enough to be able to see, and capture results over a period of time where you might expect to see things changing. And then we were also quite struck by the concurrence of these themes with some of the international literature. So this is just a snapshot from a Nuffield Trust report from the UK, looking at integrated and community-based care. And you can see lots of similar themes coming out here. So the recognition that planning and implementation takes time, being clear about outcomes, considering context, this idea that hospital use and costs are not the only important impact measures, and kind of paying attention to the process of implementation as well as outcomes. So that's linked at the end of our report, but just interesting to see how in very different contexts the kind of similar things are coming out. So
just reflecting where we're at now, so systems don't stand still and wait to be evaluated. Certainly what we're seeing in New Zealand as primary care continues to evolve, and our analysis is the next couple of years may actually prove a pivotal point. We outline further that there's been quite a light touch sort of policy environment from the top of the system in terms of some of the initiatives in the last few years have been setting out examples of best practice and then leaving it over to the sector for them to identify what they want to pick up and use. Certainly there's been a wariness about organisational change given the myriad of changes that went ahead in the 90s and the cost and the time and the effort that went into those changes, often at the detriment of other longer term health system issues. So But equally, we may be in an environment again to look at organisational change. What we are seeing is a new government with new policies. They've flagged a health and disability system review. There's definitely changing patterns of practice ownership. As I said, you're seeing new forms of business practice emerging amongst investors in different practices, as well as the cementing of Māori and Pacifica Māori and Pacifica-led PHOs of practices. The Waitangi Tribunal is doing an investigation in how much primary healthcare has delivered for Māori. Over the last few decades, it's been a long-term policy direction, but how much has practice and change been seen on the ground? And they're certainly asking some hard questions there of what the health systems delivered. And there are other models of care out there and emerging technologies. We only looked at healthcare homes. We're very conscious that there are other creative work happening. So with that in mind, we've also embarked on a broader primary healthcare research program, so a 5-year program grant funded by the Health Research Council. This grant recognises again all those levels that a system operates, from the macro, meso to micro levels. We are looking at, and we've got 5 different projects. This also represents a system view of primary health care, all the different expectations of what it would deliver, the different ways you can think about better integration and models of care in the system. But we've got 5 projects underway, just started literally this month. So the first looking at macro trends in primary health care, really asking, given all the new money that was put in 2001 to deliver better access and other forms of primary healthcare delivery, what can we see as a result? So some interesting modelling work there with some new linked data sets that might be available. We're looking also at changes in primary healthcare service delivery and what are, just confirming possibly some of the things we've identified as barriers and enablers that we're less certain about. What does it mean across the system in terms of policy, governance, strategy and planning, by doing a bigger survey of all PHOs across New Zealand, mirroring a survey that was done in around 2004 when the primary health care strategy was first implemented, looking at the change that's happened more collectively rather than just through the healthcare home lens. Equally, looking at other new models of care and case studies, Project 3 there. Particularly, we've got a project underway looking at how pharmacists are being part of new team-based care, and we're also looking at what it means for Māori health and integration for Māori health in primary care. So 5 projects linked across different system levels to get to actually fill some of the gaps that we identified in this initial stock take for the New Zealand Productivity Commission on primary care innovation. So that's our overview of what's been happening. Thank you, and happy to answer any questions. I mean, what that was an initial look to try and understand system innovation, both using historical research and system understandings and early work theorising how models of care do get picked up in a system.
Thank you, Leslie and Phoebe. So you can type any questions you've got in the Q&A button. If you move your mouse around your screen, you'll see it at the bottom of your screen. So do we have any questions for Leslie or Phoebe? From Maria Bautista. She said, when you say capitation as a barrier, are you looking at any changes in this? And in what direction?
Maria, so I think it's the form of capitation that New Zealand has introduced as being the barrier. So I think capitation alongside still allowing out-of-pocket expenses. So in fact, it's a barrier in the form it's been introduced in New Zealand, because it still allowed general practices to charge fees on top of getting a bulk amount of money. So it still allowed them to actually, rather than see it as their total income that they then have to manage within, it feels like a base income they then need to find services on top of it. So that's the way it's become a barrier. I I mean, it's always been billed as one that would allow more innovation to occur and to actually manage change within the system. And we've seen some innovation occur, but I think it's been slowed in New Zealand because of the way it's been implemented alongside fee for service. And in terms of, are we looking at any change? I think very much this health system and disability review will be looking at it strongly. It's become quite a big topic of conversation across New Zealand. Yeah.
Thank you. Have we got any other questions? I think that might be it. Thank you again, and we've got Leslie and Phoebe's email addresses there, so if you have got any questions that come up once we go offline, I'm sure they'd be happy for you to email them with them. Yep.
Certainly.
Yep. Great. Thank you. Thanks, everybody.